Hello, everyone, and welcome to NASIT's 7th webinar. Thank you all for joining us tonight. We will be watching a thyroid nodule thermal ablation recording by Dr. Leo Rangel, who is a head and neck surgeon at Rio de Janeiro State University. We're also joined by two panelists, Dr. Michael Dweck, who is an interventional radiologist at UCLA, and Dr. Chelsea Baldwin, who is an endocrinologist at George Washington University. Thank you all for being here. And I am Katie McManus. I'm an endocrine surgeon at Columbia University, and I have the honor of moderating this discussion. So we're gonna play the recording and pause throughout to highlight different things and ask our panelists some questions. We'll also be monitoring the chat, so if you have any questions, please feel free to put them in the chat so we can address them. So without further ado, I'll have Leo share his screen and we'll start the video.
Oops. So this is the video. It's a pleasure to be here. Thanks for the invitation. It's a pleasure to be in this initiative. And we are just going to discuss a plain video. So this is a right side nodule, just showing that as I do it, the nodule from the head, the image is inverted. So you see it as in the left side. It is a very well vascularized nodule. We can also address elastography. That is also quite important. And here's the planning. I generally try to teach this. So I think it is useful to address the best position where you can put your skin incision. So I mark the inferior edge of the nodule, the superior edge of the nodule. Then I try to scan as a fan movement and try to position the nodule inside all the way. So we try to find this intersection where the best position where I can get my needle into all sectors of the nodule.
I'll have you pause there, Leo, just a couple questions. First of all, I see it was a little small, but for someone who didn't see the size, this is a 45 by 34 by 26 millimeter nodule. So is there an ideal size range for ablation?
Michael, well, you have the experience of the big nodules. What do you think?
Yeah, that's a great question. And it comes up quite a bit. And there's no firm criteria in the literature that says that there's a size which is too big or anything like that. As a rough rule of thumb, I think this is a great nodule. The one that Leo is showing, the volume here is about 21 cc's if you calculated this volumetrically. 20 cc's, I think, is a nodule that's easily addressed in a single session. When it gets up 50, 60, that might be a little bit more of a stretch to do in a single session. When it gets up, for me, when it gets up to about 80 cc's or so, I know that there's a high chance that I might have to do this in 2 sessions. I mean, that said, we've done it at that size, but I love a nodule like this one that's a little bit more manageable at about 20, 30 cc's, where comfortably we're going to get through this entire nodule in a single session without too much trouble.
And Chelsea, do you ever use 2 separate entry sites, so 2 separate pokes if you have a larger nodule?
Yes, if the nodule, so Leo showed nicely the spanning that you do during planning, trying to pick the trajectory of your needle. If you can tell from the original trajectories when you're doing your planning that you're not going to cover the entire volume of the nodule, then it is best to think of doing 2 insertion sites. And so a larger nodule, probably above 30 cc's, I'm thinking there's likely going to be 2 puncture sites.
All right, thank you.
as a rough rule of thumb, I've heard it said that if the long axis, the CC dimension is greater than 4 centimeters, that's where you might have to pick 2 separate puncture sites as a midway point. Every nodule is variable, but that seems to be fairly true in my experience as well.
Yeah, it also depends on the patient's anatomy. Sometimes the patient has a large chest or a short neck, or sometimes don't even extend the neck too much. So maybe it's going to be necessary to do more than one insertion.
Okay, great.
So let's move on. So hydrodissection, I think it is one of the key points of the radiofrequency ablation itself. So because it allows you to protect these adjacent structures that we have here. So here I'm using a 22 gauge needle to hydrodissect with the superior capsule of the thyroid with 1% lidocaine without epi, just plain lidocaine. So we try to find the capsule and create this space. So generally, I don't use more than 10 cc's. Then I change to a spine needle that will allow me to go over the nodule. And as it bends across the nodule, I will be able to really dissect that nodule away from the anterior capsule and also the carotid sheath.
Does anybody do a cervical nerve block or any other additional sedatives or under conscious sedation? Does anybody use anything besides just the local anesthesia?
I do. So for the infusion of 1% lidocaine, that's what we use for the anterior capsule. But we will also give the patient a milligram of Xanax prior to the procedure for mild anxiolytic. Can really make a huge difference in how well the patient can sit and tolerate the procedure.
I do the same. I typically will prescribe 2 milligrams and have the patient take 1 milligram about an hour before the procedure, and the second if they're still feeling anxious right before. That's something they pick up at their pharmacy. They bring with it the day of, because we typically don't have nursing available for these. And then I had a question also. I have been using almost the exact same approach with the 22 gauge needle, but I'm wondering if you guys use a longer acting for the pericapsular anesthesia, longer acting anesthetic. I use some lidocaine mixed with bupivacaine just to get a little bit longer duration. It seems to work well. I'm wondering if you guys have had that experience as well.
I've heard that several times, but have yet to use that.
One thing that is kind of useful if you have the opportunity to do the fine needle aspiration of that patient prior to the procedure. You can have a feeling if the patient is too jumpy or feels too much pain, and maybe it's something that we can titrate into having something or not. Some patients tolerate very well, and I have never used HOPE. Sometimes if the nodule is too big or the procedure takes too long, I might pre-inject lidocaine a little bit at the end of the procedure.
Okay, great.
So one thing that I'm currently doing more often than not, now I'm finding it very useful, is to hydrodissect the posterior capsule of the nodule, the thyroid. So I'm doing the hydrodissection of the trachea. You can see on the video that the needle really bends, so outside of the neck, so you can make an arc. It's very useful. So we try to find a plane between the trachea and the isthmus. So this is the easiest way. Sometimes you can do this for this approach. We can also transect the nodule and inject directly in the posterior caps of the thyroid tubes. There's no problem to go through the nodule. So this way I create a space between the trachea and try to put some liquid close to the recurrent laryngeal nerve. In that sense, trying to avoid the increase of heat that it may be during the procedure. So see here, we have normal thyroid below the nodule. And in this area, I'm using only 5DW, V5W, right? Not lidocaine, because I don't want to block the nerve.
And do you ever leave the needle in if you're planning, once that kind of resorbs, to need another injection, or does anybody else have another way of doing the hydrodissection?
For those benign nodules, generally I don't, but I know that the Dr. Beck from Korea, he has an assistant doing the injection, especially for recurrent lesions in the central neck. Michael, you do this too, right?
Yeah, I think this beautifully displaces the trachea. I don't often have that much luck, or so I do.
I choose a nice one, right?
I do have the ultrasound technologists that I work with. I often have them actively injecting if I'm near trachea or other structures, especially for PTMC or autonomously functioning nodules, where it's really important that I get an adequate ablation of the margin. Sometimes I'll have them actively inject while we're ablating, while we're near that margin. Really nice if you get a good result like Leo, where it displaces and stays displaced, then I don't think that's necessary, but sometimes that's an option too, to actively inject.
Yes, definitely. You actually address a very key thing, because when we are talking to more advanced cases, it is different from ablating a benign nodule that we just want volume reduction and symptom relief, than the autonomous nodules or the micro PTMCs, because those nodules we need to compromise with the results at the oncologic or even the endocrinology result as the normalization of the hormone. So those cases are really more challenging. So I would say that the autonomous nodules are the most challenging ones.
Yeah.
Even than PTMCs.
Yeah.
And now to the part where everybody do a little bit different. Everybody does a little bit different this. So ablating itself. I like to make a small stab on the skin, so the electrode does not really round the skin. So then we have just a straight. Generally, I start from the lowest part of the nodule. So because if in an eventual edema or something, and the nodule may be pushed into the upper mediastinal, I can lose the inferior edge of the nodule. So I rather start from the inferior and go to superior part of the nodule. But I guess it is just this reason. And as we start in the inferior edge of the nodule, we need to acknowledge that the nodule is like an egg. So the inferior edge is smaller than the central area of the nodule that we measure. So we need less ablation spots on those edges. So I did just one in the inferior area, and now I'm doing the moving shot in this inferior area of the nodule. So then I'm moving. So I did a inferior track. So that's one problem, that why hydrodissection may be a key thing, very important, because we start, the first track that we do is a lower track and also a medial track. So it is close to the nerve. So try always to start with the lowest power that you can in this area, so you get a sense, because we actually cannot anticipate how the ablation is going to work actually the first time. So I would say try to start with 25, 30 watts when you're starting, and slowly crank it up like by 5 watts if it's not working. How do you guys do it? Do you do like this, or?
Yeah, I think 30 watts is a good, comfortable starting place for the posterior edge of the nodule. And of course, working from the most posterior aspect of the nodule, working interior. And I too like to start at the posterior portion of the nodule. I feel like the patient's able to, or more tolerating of extension of the neck and kind of tires with that as the procedure goes on. And so I find it easier to go ahead and knock out the lower hole as soon as possible.
And maybe it's a good idea, Leo and Chelsea and Katie, just to talk about the choice here of generator and electrode size, and or antenna size in this case. And
Yeah, I really like the 7mm. So here I'm showing the long axis of the ablation area. We can see here the area that we ablated from. We can telling apart from the area that's not ablated, right? So the area, so we can measure the area that we ablated. So it's we ablated 1.5 centimeters, then we move to an untreated area. So it's pretty simple. So I rather use radio frequency. So I really like the 7mm active tip. I think it's like my do it all. Rarely I use really larger ones. So because I have the sense that I already know how it's going to respond on every nodule, unless it's a micro PTC, and I might use a smaller one, but rarely I use the 10 millimeters active tip.
interesting. And I
Yeah, I think oh, go ahead, Michael.
I was going to say I like the 10, and I typically start at 40 and move from 40 to 60, and more recently using a variable length where you have electrodes where you can change the size from 7 to 10 or even 15 if you want. I've been using that a little bit more as well. But
yeah, because when you change the active tip, you also need to change the power that you're delivering, because it's so I rather not change, but I rather know more or less the amount of power that I'm delivering, that I'm using with that active tip. So yeah, I have the sense. So if you change every time the length, sometimes, for example, you start with 40. That is okay if you're using a 10 millimeter active tip. Right. Does this it does the same amount of energy dispersion that probably a 30 watts would do with 7.
Yeah, that's right.
Yeah, that's a really good point, Leo, is kind of once you have that needle tip length that you're comfortable with and knowing how the energy is going to be dispersed within the tissue, that familiarity is nice and leads to more reliable results. And so my preference is for a 10 millimeter, but I'm usually treating, large benign nodules, not so much these smaller cancers yet.
Yeah, definitely. No.
We do have one question in the chat asking if anyone's operated on a lobe after an ablation and whether it's more difficult with scarring, things like that. Has anyone had that experience?
Yes, yes, I did. So it's not any difficult and more difficult than any other case. So you get a little bit of scar on the superior aspect of the thyroid, but not at all on the area that matters, the posterior area close to the nerve, because of course we try to stay away from that area for obvious reasons. So it's not really difficult in that area. It's pretty same.
I think that's kind of in contrast to operating after an ethanol ablation where
Right.
Yeah.
there's more scarring.
Yeah, definitely. So here I treated almost half of the nodule. So we can see that we have vascularization on the untreated over the untreated area, and the area that was treated, the vascularization is off. So we keep moving superiorly. So it is important to have this stepwise approach to the nodule, so you don't leave any tissue behind, any tissue untreated behind, because if you need to go back, sometimes it's more difficult to tell the tissue that was treated from the one who wasn't treated. What is, Michael, Chelsea, how is your mental process on treating the nodule? Do you do this way too, or is
Almost identical, Leo. I happen to start at the superior aspect of the nodule, but I think you have both offered some compelling reasons on why the inferior nodule would be a better choice. My rationale is because sometimes we're dealing with very big nodules. And so I start superiorly. The thinking is that if I don't get through the entirety of the nodule, maybe I cover half or 2/3, as the superior portions regress in size, the inferior portions will pull up. And I've heard others say the same, and that subsequently, if you go back a month later for the second half, it might be easier, more central in the neck. And so that's been my approach, but yeah.
Definitely. Yeah, you made a very good point. And definitely, if I have a nodule that I consider doing in a staged ablation, I would definitely do that way that you talked to. Definitely. And
yeah, I've heard that similarly being proposed for, substernal goiter, the patient that you're going to do multiple treatments in, thinking that of course you'll have the substernal portion rise in the neck after the treated portion shrinks. But as far as technique and stepwise methodology, it's almost identical to what's being shown, always starting at the most medial posterior portion of the thyroid or nodule, either using the superior start point or inferior start point. And of course, you're just trying to avoid the artifact that shadows, where you've already treated. And so being really careful to make sure that you're moving anteriorly so that you can continue to visualize your needle.
That's a great point. And Chelsea, how do you decide as you're going when to start pulling back on the needle? Do you follow impedance? Do you listen to audio cues, or just pay attention to the ultrasound changes?
So probably a combination of the hyperechoic changes that I'm looking for. Those help me know if I have the right power. And then I am looking for there to be that jump in impedance as well. That's reassuring that the tissue has been adequately treated, usually looking for that jump at least over 100 ohms.
How about you, Mike?
Yeah, for me, I've always been more oriented around the sonographic echogenic response before retraction, but as those audible cues are more available, and software that comes with degenerators gives you these audible cues, I have found myself pausing just a little bit longer to get the very beginnings of an impedance ramp up. Yeah, a little bit. And even I use the Cambridge device today, and the pump will stop and you'll get a temperature also immediately. And so that's interesting. I don't know that it's really changed the way I retract, but it's interesting sometimes to pause and see how high your temperature is going, make sure you're getting above 50, 60 degrees where you really want to get an adequate treatment zone.
Yeah, I think that especially for the first cases when we are trying to start the ablation, as most of people still are doing, I think that to track the image changes, I think it's paramount, because when you see those hyperechoic changes, you know that around the electrode you get 100 degrees Celsius. So if you get 100 degrees Celsius close to that electrode, you definitely get temperatures of up to 60 degrees Celsius for close to 2 millimeters of that area. So that's sufficient, that is more than sufficient to kill those cells around the electrode. So we don't need to over deliver energy, because if we deliver too much, the risk of complications also increase. So we still need to have better equipment to say when enough is enough. So probably we're going to see this in the future.
I also see, I don't know if anybody's looking at the patient in the corner, but occasionally you could see her talking and answering questions. So can you tell us about kind of what's happening there? Are you asking questions intermittently, or what if they fall asleep? Do you
No, I wake them up. Oh, that actually I got from Catherine Sinclair. So she's the lady with the nerve monitoring thing, right? So and so she went from very difficult, very high-end nerve monitoring to talking to the patient. So now I'm just following her lead. So this is completely hers. So I that doodly do. I get the patient counting to 10 when I'm doing the inferior part of the nodule. When I close to the nerve, so I'm going to start the ablation and I say count. So 1, 2, 3. When I move out, and I say, okay, stop. And inside the thyroid is just fine. So I don't have them counting. So it's a little bit bothersome, but it's quite very useful, because if you have any voice changes, you see it immediately and you stop and you try to address it with cold water. So this is the final aspect of the nodule. So completely ablated, you only have vascularization remaining on the outside. So, and it's amazing how we see that the normal thyroid tissue is completely preserved from the ablation. So it's amazing how we can just treat the nodule.
And when you're turning on the flow, just wondering about the vessel ablation. If you ever do vessel ablation, do you do that at the beginning? Do you do that at the end, or kind of both? And what's the reasoning behind doing the vessel ablation?
Michael.
Yeah, first, Leah, it warms my heart your use of color Doppler as a radiologist. I really think I appreciate that. I rely heavily on color Doppler, and I do in the beginning. If I see some prominent feeding arteries, especially, I will often address those initially. Small things I don't worry about too much, but if there are some dominant feeding vessels, and the idea there is that you will disrupt the vascular supply and thereby decrease the blood flow through the nodule and decrease the heat sink, and your ablation will be more effective and will be quicker. And actually, just anecdotally, I feel like as we treat the nodule, the latter half goes quicker because you've taken out some of that peripheral feeding vascularity. So I don't do it on every case, but I will do it if there's easily accessible feeding vessels. And then during the ablation, when I'm at the margins, if I see some adjacent vessels, I'll treat those similarly. But I'm curious how you guys handle that.
Chelsea?
So for large feeding vessels, if they are where I think is safe to treat, then yes, I'll target them. And then again, always being concerned about whether or not I'm going to cause shadowing. If the vessel is on the anterior aspect of the nodule, I won't go after it initially for fear that it will obstruct the view of the rest of the nodule for the treatment. And so that would be saved for the end of the case.
Perfect. I think the vascular ablation is very key on especially two situations. Actually, when we are treating autonomous nodules, so we really need to address those vessels, lymph nodes and parathyroids. So then you have those feeding vessels. And sometimes it's easier when you get the feeding vessel, then it is, you get the tissue a little bit more firm, and it's easier to get inside. I find this very, very useful too. And also we are talking about impedance. So it is one moment that I would wait for the impedance to increase, to have that jump, because the vascular ablation, you need to wait for the impedance, so you know that the tissue is all dried and devascularized. So for micro PTCs and for vascular ablation, I would wait for the impedance. Otherwise, I would just tailor by the image.
And can you take us through what you're looking at here?
Oh, so it's something that I do often, is to try to check the vocal cords before and after the procedure. So it is something that most of us do not do it routinely, but you can check that. So before and after the procedure, and sometimes before going to the other side, sometimes you have bilateral sometimes. So you check the vocal cords, you hear the patient, but you can also check the movement. So once you see those vocal cords moving equally, you can definitely go to the other side. You know you did a good job.
Leo, are you just passively observing the vocal cords? Or are you having the patients phonate, or what do you do?
Sometimes phonating, the box, the larynx go up and down, but just breathing or whispering something, it will open and close. You can get those.
And you brought up a good point about treating nodules bilaterally in the same session. Do you do that? Is that something you try to avoid, or how do you handle it?
Having two equal nodules bilateral, probably too much, but sometimes the patient has one benign nodule that is dominant on one side and a smaller one that is also benign on the other side. So why not? Sometimes the needle is most of the time is expensive and out of the pocket. So if you can get those nodules, sometimes not that big, but it's also a big nodule on the other side, why not?
Mike, do you ever do bilateral nodules in the same session?
Similarly, I have, if you have large nodules and it's going to be a reasonably sized ablation, I don't do it on both sides. There are occasions where I have taken a big nodule and then maybe one on the contralateral side that's seated safely a little bit more anteriorly. I've done that for multiple autonomously functioning nodules that were relatively small, where I've gone bilateral. I tend to avoid it though.
How about you, Chelsea?
Yeah, routinely I do not, just for concern of swelling and how long the patient can tolerate being, in the procedure. And so typically limited to one.
Yeah, Very well put it. Yes. Sometimes
one
too
thing-
much.
One thing we didn't touch on at the beginning, but in terms of the positioning of you, how you're positioned, is everybody in a similar position at the above the head, seated? Does that change depending on the side?
For me,
So for me, I'm always at the head of the bed.
yeah, likewise.
Yeah. And I do it seated. So because when I'm doing standing or in the side position, sometimes the back hurts. I find this position useful, comfortable, and you can get very precise by resting the elbows between the patient's ears. So it is quite useful.
Did it take anybody a while to adjust to using their non-dominant hand?
A little bit, yeah.
A little bit of a learning curve.
I think practicing with FNAs is a great place before you go to ablation. The other thing that actually takes a while is being at the head of the bed and right is left and left is right and you're upside down. That took a case or two to really figure out way back when.
Yeah, it is.
Agreed.
And then in a couple of things about after, do you prescribe any steroid taper? Is it dependent on the case? I'll start with Leo. What about you?
Yeah, well, since we had started talking about nodule ruptures, and I've never had a nodule rupture so far, but talking to other guys and hearing what people are doing, so I decided to start using steroids. I do long-acting steroids. I inject them. So I still think the nodules, the ruptures, are close related to the amount of energy that we deliver. So everybody that I talked to that had nodule, that had a rupture, they weren't on the first cases. They were after the learning curve. They were comfortable delivering more energy than they in the first cases. So I guess it is something to about having a lot of energy delivered to the nodules.
So you'll actually inject steroids?
On the muscle, not systemic, not into.
Okay. So you don't do a PO steroid prescription?
No. I just inject them and send them home.
How about you, Chelsea?
I don't routinely. Of course, there's individual cases where you might be a little bit more concerned and think that it's necessary, but on a routine basis, no, I don't use a steroid taper.
How about you, Mike?
No, nor do I have used it again in select cases. I send patients home with some ice packs and 48 hours round the clock ibuprofen. And most people get through just fine. I have used steroids, prednisone for 4 or 5 days in a few cases, but not often, not routinely.
Okay. And we have one question in the chat. Interested to know opinions on offering RFA for nodules with Bethesda 3 cytology and negative molecular testing results. Anyone want to tackle that one?
I can start there. Yeah. So when you have a biopsy with a Bethesda 3 result that you've gotten negative molecular testing on, if the molecular testing, standard, it's usually less than a 3% chance that you have a misdiagnosis of a thyroid cancer. And so therefore, it's just as good as biopsy being negative. And so it seems to me reasonable to treat these nodules that have a negative molecular profile.
Yeah, well, the Bethesda 3 may be addressable. I am more worrisome about the Bethesda 4 and the follicular lesions. So, yeah. So when we had that beautiful talk on the last NASIT from Dr. Nikiforov on that lecture on follicular lesion and the pathway of the RAS mutations. So even if we have a benign lesion that is from follicular origin, I would regret doing this ablation, not because I don't trust the result now, but I would put in the, as we now they address as currently benign, not a lesion that might progress in the future to something that we don't know. And so as we are now removing that lesion, we may have still some cells left that may progress to something. So as a rule of thumb, we have molecular tests in Brazil, but I decided to do radio frequency ablation when I look at the image and I believe it's benign, and I have a cytology telling me that it is benign.
And so
Michael.
that's just for Bethesda 3, right?
Yeah. Bethesda 3, yeah, I take this out. You know, I'm a surgeon, so I would take it out.
And for
or do nothing, or just watch.
Our practice is very similar to Chelsea's. If we have Bethesda 3 nodule with benign molecular markers, we treat that as analogous to a benign biopsy, and we still require 2 such benign biopsies, but that's how we've treated.
And another question from the group: would you consider RFA larger than in PTC larger than 1 centimeter? Or what's your cutoff? Or is it 1.5 or?
Yeah, it is a mixture. It is if position, the size of the thyroid. Sometimes you have a decent sizable thyroid that the nodule is right in the middle of the thyroid. Sometimes you have a very small thyroid and the 1.1 that is occupying almost all the lobe. So it really depends the size, from the size of the thyroid, the size of the tumor, and where it's seated to really decide the superior edge of that ablation. And I still believe that from when we move from the PT1A to PT1B, without any neck metastasis, just 1 lesion, we are going to a chance of recurrence from 1 to 2% to less than 5%. So it is still very low chance of recurrence. So I would, if it is doable, I wouldn't say it is a contraindication to do a 1.5, 1 point something like that.
How about you, Chelsea?
I mean, I think it's definitely the clinical scenario, as Leo outlined very nicely. You know, where is this PTC, located in the thyroid? How close are we to dangerous structures? Does the patient have any option for surgery? What is the full clinical scenario? And so biologically, I'm not sure that there is something different about an 8 millimeter PTC versus 11 or 12. So it really would be the clinical scenario that would drive whether or not we would choose to treat.
Okay. And another question from the group is about partially cystic nodules. So is there a solid cystic ratio that you prefer or would be appropriate for RFA? Mike, we'll start with you.
Yeah, I think nodules that have, that are predominantly cystic are better treated with alcohol. I don't have a strict cutoff, but what I will sometimes do is if there's, say, a 50-50 cystic solid component and the cystic component is sizable, I sometimes will treat with alcohol and see if that obviates the need for subsequent RFA. So treat with alcohol, bring the patient back a couple weeks later and see how they're doing. And if there's still local symptoms, then can consider doing subsequent RFA. And then the other consideration is how to handle them technically if you're going to do it in one setting, if it's a cystic solid nodule. I will typically aspirate the cystic components first, just to get the fluid out of the way, to prevent charring at the needle tip, to and aspirate as much as I can, and then address the solid components with our RFA.
Leo, any,
Yeah, I agree.
or Chelsea, yeah, go ahead.
Yeah, this stepwise approach, as Michael was saying, is kind of very well described in the literature as well. And so if you have a large cystic portion, probably 40% or greater, trying to aspirate and treat with ethanol, and then it's known that you could then subsequently treat with RFA and get effective outcomes if you were not able to get your volume reduction to the patient's goal. The other thing that I wonder, Michael, has slowed me down a lot with ethanol is the price and getting ethanol. And so some of the original cost benefit ratios, because we actually know that using RFA right off the bat for even, nodules that are mixed solid cystic is quite effective. But the argument was always that ethanol ablation was cheaper, simpler, but now it's become much less simple that I can't get a hold of ethanol for an affordable price.
That's true. That changes the calculus entirely. It's crazy that it's so expensive, but that's a really important point. That's a good point.
Definitely. Yeah, I do think the same. In Brazil, it's still quite affordable. It's more affordable to use ethanol for those lesions. So I do tailor this though and try to select the patients as Michael just said. So I think it is very reasonable. And once the prices are, normal range. So, but definitely the radio frequency ablation works indistinctly from cystic, purely cystic, mixed and solid lesions. So that is the greater. So that's why we're discussing this. So that's why we have this, because now we have a technology that can handle every single kind of nodule. So back in the day, only very cystic lesions could be addressed by a direct therapy. Now we can have like that nodule that I just showed that is completely solid.
Just one additional complexity is I have not had patients be not covered by insurance for alcohol ablation. So sometimes, you're going to get covered for alcohol, you may not for RF. So sometimes that steers us in one direction. Shouldn't, but sometimes it does.
Sure, definitely would.
And another question from the chat, Mike, you were talking about ablating larger nodules, and this is related, I think, in terms of approach to sort of a confluence of nodules causing compressive symptoms rather than just like one discrete nodule. Do you treat it as if it's one nodule? Would you consider doing an RFA for that?
Me personally, yeah, if you have within a lobe, if you have confluent multiple nodules, I would treat those as, yeah, just as if they're a single nodule. The challenge becomes when you have a bulky bilateral multinodular goiter, and we're seeing a fair number of these, maybe just because patients are waiting so long. And so then what do you do? And patients come in and they're saying, I'm not having surgery, period, and I want ablation, and I heard it's so great, and you've got 200 cc lobes in each. That's a challenging discussion, and one I'm really interested in hearing what everybody thinks about those, or how you address those situations.
Yeah, those are tough. Those very large nodules. Well, for start, how to address the proper volume. So when you do ablate those very large, bulky nodules, multinodular goiters, one thing that we need to consider is how we're going to refer those patients back to the primary cares. So, for example, when you ablate and you got all that nodule, hypoechoic, irregular, so they had like multinodular goiters. So where those nodules went. So we need to at least follow that patient in a sense that we need to have at least some ultrasounds that's showing that the whole thing reducted, and maybe we can have a picture showing that. So now that's how it looks, that lobe. So it looks like this. It's weird. So TI-RADS does not work now, but we know it's benign. We had several biopsies showing that everything is benign. So those measures may avoid a late surgery that we actually wanted to avoid, but we end up like drifting that patient to surgery because we made a confusion on the diagnostic and the appearance of that nodule. So we need to have that patient very clear that the whole area is benign and that we treated everything and the volume is the same. I'm saying this because I just had a patient that I had 2 nodules on the same side. They weren't confluent, but they are almost touching each other. After the ablation, the first month, I could tell them apart, but after that they merged, so they became just one. So she had an ultrasound outside of my clinic, and she called me, doctor, the nodule grew back. The nodule is huge, and said, the nodule already grew. It's not very common. So yeah, one nodule disappeared and the other one grew. so actually the word they are combined, so they measured just one nodule. So then I need to do the math and sum the volume of both nodules, and now I'm following as just one volume. So that's one tricky thing about those very large nodules that you need to treat.
Involving extra math is,
yeah, a little bit of more math to it.
One other question that came up in the chat on our earlier conversation about a cystic solid nodule. If you have a nodule that has smaller cystic portions that are really too small to go in and drain, are there any techniques, and you're using RFA, are there any techniques you use that are different from just the standard solid nodules to help address those small little pockets of fluid?
I think for me, no. If the cystic pockets are small enough, the moving shot technique is still quite effective. You might have a little bit more popping, and so preparing your patient for that would be wise. Patient expectations really can help make the procedure go much more smoothly, but that would be the big difference that I would foresee.
Yeah, and maybe your ablation is going to be quicker, and so maybe you're going to retract quicker through that region. But I agree, no substantive changes to technique.
I would add, great question, Dr. McGill. Lovely to have you, Debbie. Sometimes when you have those large cystic spongiform nodules, the problem with those, as more colloid we get, the chances of having charring around that's the electrode increases, and sometimes you need to clean and those nodules. I see why you're talking about that, and trying to evacuate those small cystic areas to avoid those charring. But actually we can, well, most of the times there are too much cystic areas, so I don't drain, and sometimes you need to remove the needle and clean a little bit the tip of the electrode too.
One other thing, just as we were talking about kind of follow-up, do you typically have patients have their ultrasound in your clinic, or if not, do you have them mail you the report, the images? How do you kind of counsel patients on subsequent ultrasounds?
Yeah, when the patients, well, Rio is a big city, so when the patients are from town, I rather have them do the ultrasound in my clinic. But if they want to do it outside, they can have it, but I rather do it myself. I do it myself anyways. When they are from other cities, I try to talk to one radiologist and I send them the pictures and so I did this. So this is this is what we might expect. And then we talk. Otherwise, the patient will go crazy, and they might have surgery because of those misinterpretations. So we need to be aware of that.
How about you, Chelsea?
Just upfront, making sure that the patient knows that the follow-up needs to be with somebody who's experienced with RFA. And so if the patient is not from the DC area and I know they're going somewhere else, either those reports need to come back to me with images, or I'm going to be looking at, my network of providers, through the NASA Society or something of the like, to find another provider who can help take over for me. For example, I've taken over some of Jen Kuo's patients that were in New York, now in DC, and it's a matter of just working with each other while we're trying to get everybody else up to speed as to what to expect with these nodules.
And Mike, what about you? Anything different or?
No, nothing different for patients that come out of state, and we have some that do. I always send them with a note that this is what's happened and these are the expected sonographic changes. And I tell them, don't let them come back and tell you have cancer. You do not. And I ask them always to send me the images so that I can do my own assessment and volumetrically evaluate those. So for any out-of-staters, which is the minority of patients, that's what I'll do. When they're in LA, I'm in Los Angeles. When they're in Los Angeles, we have a pretty big network in our system, in the UCLA system, where we have in our department, many sites where they can get their imaging, and I have access to it, and everybody's attuned to RFA. So yeah, not too much of an issue, just for patients that are coming from places where there's just no familiarity with RFA. Do I make a bigger deal of it?
Yeah. And I guess in conjunction with ultrasound, how about checking thyroid function tests? When do you do that afterwards? How often?
I know my protocol. I try to see patients at 1 month, 3 months, 6 months, 12 months with ultrasound at each step. As my clinic has gotten too busy, I sometimes will skip, especially the 1 month visit if the ablation has been nice and complete. In patients that come in with no abnormalities of their thyroid function test, I will check it one time post-ablation, usually at that 1 month or 3 month visit, but I won't, serially check it, but I do check it pre and post just to make sure for those benign non-functioning nodules.
And try to avoid checking the TSH too early after the ablation. You might have some suppression of the TSH just because of the procedure. So I only check it around a month, and if I need to skip a visit, I would skip the 3 months because it's too early in the curve, and I would see the patient at 6 months and 1 year.
Yeah, I don't have anything too original to say there. So 1 month, 3 months, 6 months, 12 months is my protocol, and I would check TFTs at 3 months.
And if you have seen any increase, do you counsel the patient that usually that will kind of go away on its own? It's just kind of a post-procedural thing if they didn't come in with a toxic nodule to begin with?
Yeah, if you were treating a toxic nodule, then of course that'd be more expected or possibility. And again, it would be if the patient's symptomatic, beta block and trend.
Yeah, that is actually a good topic. When you retrieve the methimazole after the toxic nodule ablation?
Immediately is what I've been doing.
Yes, me too. Yeah, I keep them with the beta blockers a little bit longer, but I take the methimazole and see what is going to happen.
Right. Because of course methimazole is going to do nothing for spilled of already formed thyroid, which is of course what you're worried about. And so really there's nothing you can do but beta block for that. Hopefully you've injured all the hardware with your ablation, and so the methimazole really does lose its purpose after the ablation. Perfect.
Yeah. But I do prepare those patients as I would do for a lobectomy for that nodule. I have those patients with as much as normal thyroid function I can get and have them beta blocked before the procedure. I would prepare them as I would do for a surgery, trying to avoid that thyroid storm.
Well, thank you, everyone. I think we're just about out of time. So thank you so much, Leo, for the beautiful video and talking us through it. And thank you, Mike and Chelsea, as well, for all of your insight and excellent discussion. And for everybody tuning in, thank you for your time.
Thank you.
Thanks so much.
Good to see you.